today about the risks of biologics and making sense of those risks, including cancers, molds, and infections. We're going to talk today about what are biologics themselves. We're going to talk about the risks of biologics and also the risks of inflammatory bowel disease itself, with specific emphasis on the topics of infection, cancer, and skin conditions such as moles. Inflammatory bowel disease is a chronic and progressive disease which waxes and wanes in intensity. There are periods of time where the disease will progress over time, and this leads in tissue damage. Consider a theoretic patient here where the black line along the bottom represents exacerbations and remissions of the disease. With each exacerbation, unfortunately, there is cumulative damage, as represented by the blue line and the shaded blue area in the graph. Over time, we reach a stage at which medical therapy is no longer successful, and surgery is the only option in order to treat the underlying disease. Studies have shown that over time there is cumulative damage to the bowel. Initially, in the first 23 months, as much as a third of patients will have bowel damage. But by the time we reach 10 years of disease duration, as many as 50% of patients will have substantial damage to the bowel wall. Fortunately, our new biologic therapies have been shown to modify the natural history of disease and can actually prevent this bowel wall damage. We conceptualize this as a window of opportunity as represented by the pink bar. During that window of opportunity, if we intervene with effective therapy, we can alter the natural history of the disease. You can see in the new graph here, there is no longer these exacerbations and remissions, and the cumulative damage of the bowel wall has been minimized. This leads to improved clinical outcomes over the long term. But what are these biologic drugs, and where does the name biologic come from? Well, biologic drugs are drugs that are manufactured in a cell line. They're produced in a living system. Contrast this to the drugs that people are most familiar with, which are more of a cookbook approach. They're chemical compounds that are synthesized in the lab according to specific steps that result in the end product. On the graph on the left, you can see the difference between a small molecule such as aspirin on the left and this large T-shaped biologic on the right. These complex compounds result in their unique properties, but unfortunately the immune system can recognize them because they are proteins that are delivered to the bloodstream. These proteins result in an immune response, and the immune system can generate antibodies, which helps to break down the drug or limits its effectiveness. You see the names of the biologics approved for treatment of inflammatory bowel disease listed here, and I've separated out tofacitinib because although tofacitinib is typically considered with the other biologics, it is actually a small molecule and is not subjected to the generation of the immune system producing antibodies. In order to prevent this antibody response, immunomodulators have been used. Immunomodulators are drugs like azathioprine and methotrexate, but unfortunately these drugs also have side effects of their own, which largely relate to dampening down the immune system further, and therefore it can be difficult to sort out what are the side effects related to the immunomodulators or those related to the biologic itself. I want to take a step back and talk about risks. When we think of risk related to the medication, but also related to the treatment. But it's helpful to put this into context of things we think about in our daily lives. A not so pleasant fact, what is the risk of dying in a car crash? Well, in the United States, it was 1 in 107 people. We consider that when we're thinking about scientific studies or biologics based on a population number of 10,000 people. Translated into 10,000 people, that would be 93 people out of 10,000 died in a car crash in 2019 in the US. What is the risk of an opioid overdose? We tend to think of this in the downtown east side population or in the narcotic addicted population. But in inflammatory bowel disease, many of our patients have excessive abdominal pain and are using narcotic medications. So opioid overdose is a real risk. 1 in 92 people died in 2019 in the US, or 109 out of 10,000. And what about being killed in a pedestrian accident? Well, that was 1 in 143, or 18 out of 10,000 people. I want you to keep this risk of dying in a car crash of approximately 110,000 in mind as we talk about the risks of inflammatory bowel disease and biologic therapies. When we ask people about their concerns about the risks of biologics, we think about the side effects of the medication, such as allergy or idiosyncratic reactions, but also the more concerning effects such as infections, serious infections, cancers, or skin conditions like moles. But whenever you have a discussion about the risk of a drug or a biologic, you also have to consider what is the risk of not taking therapy? What is the risk of the disease itself and not being on therapy? In clinical trials, this is referred to exacerbation of the disease. So what are the infections that we're concerned about with biologics? Well, they're common respiratory infections, of course, COVID-19, or reactivated infections like tuberculosis or pneumonia. Viral infections such as herpes zoster or shingles. Hepatitis B can also be reactivated by biologics. And then opportunistic infections like C. difficile. C. difficile is an infection of the bowel that is similar to IBD and causes severe watery diarrhea, and so the symptoms can be confused for a flare of IBD. And then, of course, when we talk about infections, we're concerned about surgical infections, which may or may not be related to IBD surgeries. Other post-operative period surgeries like orthopedic surgeries increase risk of infection would be concern if a patient is on a biologic. And of course, for Crohn's disease, abscesses and fistulas can be exacerbated by the biologic therapy itself. When we look at the specific agents, anti-TNFs commonly have viral infections such as influenzas, pneumonias, and shingles as increased risk. And this risk is increased particularly when taken in combination therapy with an immunomodulator. Of course, COVID-19 is on everybody's mind these days, and we'll discuss that briefly a little bit later. And then, as I mentioned, opportunistic infections like TB and C. difficile. Vedolizumab, a newer drug which is gut selective, does not have this increased risk in viral infections. There is an increased risk in C. difficile, of course, because vedolizumab is confined to the gut, and that's where C. difficile acts. There's possibly TB seen, but of note, this was only in patients who'd previously been on biologics. Ustekinumab does not carry an infectious risk, and while tofacitinib does, the main concern there is herpes zoster, which was seen in as much as 5% of patients on the full dose or high dose of tofacitinib. But it should be noted that those infections were generally mild, and that we can mitigate that risk through the use of the shingles vaccine. Where does our knowledge of infections using anti-TNF therapies come from? Well, the best and perhaps biggest study was something called the TREAT registry. The TREAT registry looked at Crohn's disease patients over a 5-year period and was a very large study. What they saw was a slightly increased risk of serious infection, and then they looked at what factors about the patients led to that increased risk. Interestingly, the biggest risk factor was moderately severe disease activity. This hazard ratio is the concept that the risk is 2.25 times as likely to occur in patients with moderate to zero disease activity than those who do not have that factor. Narcotics was also a big risk factor at almost twice the risk of the patients who are not on narcotics. And you see, we make our way down to infliximab, which although the risk was increased, it's not a substantially increased risk, especially when you consider the effectiveness of these therapies. Another way of looking at this is opportunistic infections in patients who are combination therapy. The pictogram here, each patient represents one patient that would acquire this condition. You have to consider this number of 10,000 patients. So these patients are out of 10,000 people over a 1-year period. You can see in the top horizontal bar for serious infections, the risk is increased on thiopurines or immune modulators, on anti-TNF monotherapy, or on combination therapy. It's this combination therapy group that does have the highest risk, but when you consider that this is out of 10,000 patients, the risk is actually still quite low. If we move on to look at vedolizumab, in the vedolizumab registration trials, which are depicted here, there was no increased risk infection for any of these infections that were studied. And this is interesting to note that the placebo group, or the blue bar, would be patients who did not actually receive the drug but were followed in the trials, and they had a higher infectious risk. You might ask, why would a placebo group have a higher infectious risk? And this relates to what we saw in the TREAT registry. People who have active disease are at a greater risk of developing an infection because their disease isn't treated. We move on to look at tofacitinib. This is the data from the registration trial. You can see there was an increased risk of acquiring any infection, although only a modest risk. The biggest concern, of course, is this risk of herpes zoster, which is not that common to occur in the general population or the untreated population, and does increase as the risk goes up to as much as 5% in the high-dose group. A systematic review and meta-analysis was conducted, and a network meta-analysis is a fancy statistical technique used to combine studies. You can see at the top that a total of 49 clinical studies were combined to achieve over almost 15,000 patients involved. And in the top two boxes, you can see that there was not an increased risk in infections, but there was a slight increased risk in opportunistic infections in the red box. This number of an odds ratio of 1.9 or 2.32 is approximately a 2-fold increased risk of having an opportunistic infection if you were on a biologic. Of note, there was not a significant difference between the anti-TNF biologics and the anti-integrins, suggesting that this would be the case for all biologics. It's important to keep in mind that we do have effective strategies and therapies to prevent infections, the most notable of which is vaccines. And for many of these viral infections that occur in patients on biologics, patients can be vaccinated to prevent the risk of developing these infections. Of course, in 2021, you can't get away from talking about COVID. So here we go, just a brief comment about COVID, and it's quite an interesting one. So a large study is being conducted in the UK called Clarity IBD. And in that study, what they showed is that patients who were on anti-TNFs and immunomodulators, that these drugs seem to suppress the immune response or the antibody formation to both natural COVID infection and to vaccination. So after your first exposure, either to COVID itself or to vaccination, the antibody levels were lower than those who are not on these drugs. However, after the second dose, the levels rise to an appropriate level that is protective. The interesting thing is the more recent evidence now suggests that those levels decline more quickly. And many of you may have heard that it's being proposed that a third dose of the vaccine be provided to IBD patients who are on these therapies. Stay tuned as we expect this to happen in the next couple of months here in British Columbia. The other interesting findings is that for vedolizumab and ustekinumab, the antibody response was normal, suggesting that this is probably a class effect to the anti-TNFs and immunosuppressants and not so much with the other medications. Tofacitinib, unfortunately, was not widely used enough to be studied in this study. This is really all I'm going to say about COVID-19, and for those of you who have more interest, I direct you to the clarityibd.org website, which has quite good information and a couple of videos. I'm going to move on to discuss the cancer risk for patients with these therapies. Cancers are typically divided into solid tumor or solid organ malignancies, lymphoma, which is blood cancers, and skin cancer, including melanoma and non-melanoma. The first questions that arises with these therapies is, what about patients who previously had a cancer and are now in remission? Can these therapies be safely used to treat their IBD? This study looked at anti-TNFs in combination with thiopurines or alone, as well as patients who are not on any of these therapies, and compared their cancer-free survival over 5 years. Cancer-free survival is a way of saying, did they develop a cancer or a recurrence of their cancer in the 5 years? And the answer is no. You can see that the lines represented by each group really are essentially the same. And so it appears that these medications can be safely used in those who have suffered a cancer in the past. The interesting thing about cancers is, with respect to IBD, they appear to arise in two ways. Either they arise from the inflammation of the IBD itself. So the chronic active inflammation is a risk factor for cancer, particularly in the bowel or as in colon cancer. The other way that they arise is through these immune suppression therapies, and do the immunosuppressive therapies increase the risk of developing a cancer? Interestingly, as our therapies have improved and our screening techniques have improved, the inflammation-related cancers are decreasing in incidence, and a recent population-based study showed no excess risk of cancer in patients with IBD. Unfortunately, the immune suppression-related cancers are still a real risk, and drugs like azathioprine do have an increased risk of lymphoma and non-melanoma skin cancer. So what about the individual drugs? Well, anti-TNFs probably do have an increased risk in lymphoma. They are not associated, however, with other primary non-skin cancers. Vedolizumab, ustekinumab, and tofacitinib so far have not been shown to have an increased risk, although for ustekinumab and tofacitinib, this was not studied in IBD populations, but rather in the psoriasis populations and the rheumatoid arthritis populations. If we go back to our systematic review and network meta-analysis that I presented earlier, they also looked at malignancies. And if you look at the box along the bottom, you can see that there was no increased risk in any cancers for patients on these drugs. And again, there was no difference between the anti-TNFs and the anti-integrins. So what about this risk of lymphoma? Well, this is quite a busy slide and a bit complicated to look at. But again, it's this comparison between anti-TNFs, thiopurines, or combination therapy in the three boxes from the top. You can see in the box in the middle, this is for anti-TNF monotherapy. And if you look down to the bottom line, you can see the risk of lymphoma was 1.49, but it was not statistically significant, meaning there was no difference in the risk of lymphoma for patients who are on anti-TNFs alone. However, for combination therapy, that risk was 5.9, or nearly a 6-fold risk. This always leads patients to ask the question, if I'm going to be on combination therapy, well, I have a 6-fold risk of lymphoma. But let's put this in context and remember back to the risk I talked about at the beginning of the risk of being involved in a car accident. The overall incidence of lymphoma for patients not on these therapies was 0.26, or 2.6 people out of 10,000. On thiopurines, it rises to 5.4. On anti-TNFs, it rises to 4.1. And on combination therapy, it's 9.5. That means 9.5 people out of 10,000 would develop lymphoma, as opposed to 2.6 in those not on these therapies. It is a 5-fold risk, but still 10 people out of 10,000. It is a pretty small risk. Contrast that with our car accident risk, which is 100 out of 10,000. It's also important to remember that most of our malignancies can be controlled quite well despite the use of therapies. We typically employ a multidisciplinary approach, and the biologics can often be continued unless cytotoxic chemotherapy is being used. The reason for this is that cytotoxic chemotherapy is actually quite effective for controlling IBD, and most patients do not require their biologic. Vedolizumab should be discontinued in those who have a primary GI malignancy because of its gut selectivity. And note, this is not a well-studied risk, but it is a theoretical risk. For non-melanoma skin cancers, the treatment's usually local excision or topical therapies, and therefore biologic therapy is not required. Melanoma poses a unique risk because of its high risk of spread and, of course, its risk for mortality, and therefore biologics are typically discontinued for melanoma. The exception would be checkpoint inhibitors, which are an immune therapy used for melanoma, and they have a risk of creating an IBD-like illness, in which case anti-TNFs can be used. I'm going to move on to talk about skin cancer. We've talked about melanoma a little bit already, and the risk of melanoma is increased in those with anti-TNF up to twofold, 1.88. But again, these studies have only been done in specific populations. It was seen in IBD, but not in the rheumatoid arthritis population. Vedolizumab did have a slight increased risk, but those had all received anti-TNFs prior. Ustekinumab and tofacitinib do not appear to have an increased risk of melanoma. When we talk about other skin risk factors for patients who are on these therapies, we talk about either IBD-related disease or non-IBD-related disease. Things like pyoderma gangrenosum or erythema nodosum are IBD skin conditions that are often well treated by the anti-TNF biologics, but they are not related to the anti-TNF themselves. Psoriasis, on the other hand, can be an independent autoimmune skin condition, or it can be actually induced by the anti-TNF. Despite the severity of this is called palmoplantar pustular psoriasis in a patient on an anti-TNF biologic, and you can see it looks quite severe and very uncomfortable, but this does resolve quite quickly in most cases upon discontinuation of the medication. I want to briefly just touch on some of the other risks which are considered immunologic risks. I already mentioned that psoriasis can be caused by the anti-TNFs, but usually that can be successfully treated with psoriasis therapy. There's a rare condition called drug-induced lupus, which can be quite severe, and it's been seen with the anti-TNFs, much less so with vedolizumab or ustekinumab. And demyelinating conditions such as MS do occur in the anti-TNFs, but again, quite rare and usually do resolve with cessation of treatment. The other more rare risks like metabolic disease and hematologic disease do occur with these therapies, but they are quite rare and again, typically resolve on discontinuation of the therapy. That brings us to the end of our conclusion. And I want to say that biologics are generally very safe and effective medicines, and it's always important to remember this. They do a lot of good for a lot of patients. They do, however, carry an increased risk of some diseases, particularly when used in combination of immunomodulators. These risks include things like infections, cancers such as lymphoma and skin cancer, and even melanoma and non-melanoma. Most often, however, that risk can be prevented through appropriate screening strategies, vaccination, and prevention strategies. It's extremely important, and one must always consider the risk and burden of the untreated disease when considering the risks of the biologics. That brings me to the end of my presentation, and I look forward to answering your questions.